Hello, everybody. Good morning. My name is Stephanie. Like I mentioned, I'm the Director of Patient Care here, so I oversee the hospice operations. I have been a nurse for 8 years, and I have been in hospice for about seven and a half years. So I have started, I've been a case manager in the field taking care of patients, managing their symptoms. I've been an admission nurse, bringing them on to service, working really closely with the physician to make sure that the patients we're bringing on meet criteria. I've been an assistant director of nursing, and now I am the director of patient care, director of nursing here at YoloCares, where I plan to be for a very long time. It's just a really great organization. Okay, so we're gonna go over the objectives today. We really wanna understand signs of caregiver burnout, understand different caregiving options available to you all, what support is provided when a patient is on hospice services, differentiate between hospice and palliative care because they are different, and understand who can receive those services. Okay, so we're going to start off by talking about when do you need to start considering caregiving support. You're caring for your loved one. When do you need some support? There are a couple of things we'll go over. Number one, of course, is if you notice you're experiencing caregiver burnout. These are common signs of caregiver burnout that you may exhibit. Some of us are aware enough to recognize that we have burnout and we say, oh gosh, I'm so burnt out, I'm so tired, and that's great. But some of us also function on autopilot and we're going, and we don't even realize that we're experiencing this type of burnout. So these, if you're noticing any of these, chances are you do have burnout. I'm sorry, if you can't read the slide, hope you can't read that either, we'll get that to you, okay? I can also email this out to everybody if it would be helpful. So easily flustered or frustrated, forgetful or foggy, extremely tired, quick to anger, anxious or depressed, hopeless or helpless, uninterested in things that you may used to enjoy. Okay, so those are just a few. If your loved one is becoming too difficult to care for physically, so this is a big one as we age, and if we are living with a chronic, serious illness, our body tires out, right? So it gets harder for us to do the things, the little things, like going to the bathroom, taking a shower, and I don't know about you guys, but if my dad, for example, needed me to transfer him to a wheelchair to the toilet by myself, I would not be able to do that. So little things like that, if your loved one is falling and you're having to call lift assist from the fire department a lot, those are all, it's physically taxing on the caregivers as well. And this one is super, super important. I can't stress this one enough. If you have the ability to, whenever you can and as soon as possible, try to get caregiving support, even before the burnout, before your loved one is becoming too physically difficult to care for. Not all of us can do that because there are things we'll talk about later that, money could be an issue or support system could be an issue. Lack of understanding what's available to you can be an issue, but whenever you do have support, it's always recommended, obviously, that you do that right away. So what are some care options available? We know we need extra caregiving. What's available to us? Sorry, I'm standing in the way. First, we have paid caregiving agencies. So these are agencies available to the community. They are caregivers who come to the home and help you take care of your loved one. They'll do some light housekeeping, help you toilet your loved one, help you give them a bath or a shower, get them all cleaned up for the day, things like that. They are not all built the same. They're not built the same, so do your research on them. Some of the caregiving agencies, they have different criteria. Some may want a minimum of 4 hours for their caregivers to be in there. Some of them are different price points, so you definitely want to do your research on that, and we do have a vetted list of caregiving agencies that we use for our patients, so I can make that available to you all as well. Yeah. Okay, assisted living facilities. Does anybody know what just raise a hand, anybody know what an assisted living facility is? Carlton Davis is an assisted living, okay, perfect. So assisted living facilities are also available. These individuals who may qualify for assisted living are still somewhat independent. They may need some medication reminders, med management. There's a dining area, socialization, so it is for people who are still pretty independent. And they do exactly what they say, they assist, so they don't do total care. We have skilled nursing facilities, so these are a little bit different. These facilities are for individuals who have a skilled need. So say mom or dad or your spouse, they fell, they needed a hip replacement, and you can't take care of them at home, so they may need to go to a skilled nursing facility to rehab. That would be on the short-term side of the skilled nursing facility. They also do have long-term beds for individuals who have a chronic need, like medical need, around-the-clock nursing care need. So individuals who maybe they have had a stroke and they are totally in bed all the time now and they need that nursing care provided to them. So they do have a little bit more strict criteria for that. Residential care facilities. Raise of hands, has anybody ever heard of a RCFE, a boarding care? No? Yes? Okay, great. So these are, they look like homes. They're all throughout our community. There's a lot. There's a lot more than you probably realize. Most of the time they are 6-bed houses, and they are licensed under the same license as an assisted living facility. So they share some common traits there, but so same thing, they help with medication management. They are more, it's smaller, it's 6 beds, so it is a little bit more intimate. There's usually 1 or 2 caregivers there. They'll help, like I said, med management, they'll do housekeeping, laundry, transportation to and from doctor's appointments, and also if they can't provide that transportation, they'll help arrange that. Another option is family, friends, and neighbors. Not all of us think about this. We don't always think about leaning on the people who we have around us. One of the best gifts you can give to people is asking for their help. It shows them that you trust them enough to help you with somebody who you hold so dear. And also, you know, it makes them feel good to be able to give back as well. So a lot of times people are just waiting. They want to help you. And this is a good option too for those who, you know, we may not be able to afford all of the things that I listed above, because there is cost associated with most of those. And we'll get into that a little bit later too. So things to consider before you make your choice. There are a few things I want to talk about. Most of all is when you're discussing options, think about what is most conducive to you and your family, okay? There are things that will work for others but may not work for you and your family. You need to think about the financial burden. Like I said, there are costs associated with these facilities and caregiving agencies. There are options to help with that, which we'll go over, but you definitely want to think about that. Visiting hours. I highly recommend when you're looking at facilities to ask them, what are your visiting hours? The last thing you want to do is place your loved one and feel like you're isolated from them for half of the day, or you're unable to get to them. So look at their visiting hours, make sure you feel comfortable with that. Some are they're more lenient and they will let you come more often than others. So definitely check that out. The level of caregiving available. Like we mentioned in the previous slide, assisted living facilities, for example, they provide assistance. So they don't do the total care. There are people who are in assisted living facilities and still need to have private caregivers come to the facility and take care of them because the facility is unable to do certain things. For example, a facility might not be able to manage a catheter, a Foley catheter, and so you need caregiving to come in and to help with that. And then the reviews. Google is a great thing. There are a ton of reviews on pretty much everything. And like I mentioned before, they are not all built the same. So it's really, really important that you do your research and make sure that you're comfortable with the reviews that you're reading, other people's experiences. There hopefully is good and bad reviews on there that can help you when you're making your decision. Okay, so before we dive into this slide, I just want to say that I'll touch on the different ways to pay for caregiving support, but it is going to vary depending on your insurance and depending on your loved one's care. So we'll talk in general about what we have learned of different insurances covering for caregiving, but this may not fit your loved one exactly. So you'll definitely want to look at your loved one's insurance and see what they do offer. But in general, Medi-Cal. Medi-Cal is going to be the payer for skilled nursing room and board, so the cost of living at the skilled nursing facility. Medi-Cal will typically cover that. Medi-Cal also has waivers available for assisted living. So assisted living can be very pricey, thousands of dollars a month. Medi-Cal does have waivers available if you qualify for full or partial payment of the assisted living cost. However, there is usually a 9+ month wait for this. So the sooner you can get on it, the better. We also have Medi-Cal covering IHSS hours. That's in-home support services. So in-home support services is similar to the caregiving agencies that they come into your home. It is not 24/7 care, but they usually will provide 283 hours per month and a maximum of up to 9.5 hours a day. So that can be split up or all at once, however you need it to be. Okay, and then we have long-term care insurance. Some long-term care insurances will cover the cost of assisted living, not all, so look into your long-term care insurance. And then we have the VA that does cover long-term skilled nursing facility placement and 10 to 12 hours of in-home care, typically. Okay. And then we have the obvious of private pay, which is, like I said, very, very expensive, but some people are fortunate enough to be able to pay for that. So private pay is an option that some people have to go with. And then there are grants available at times. We have used Del Oro for caregiving grants for our patients. And what they can give you really depends on what you qualify for, but Del Oro is one that we use a lot. Okay, so we're going to shift gears a little bit and we're going to talk about palliative care, and then we'll get into hospice care and the differences between the two. So what is palliative care? Palliative care focuses on easing pain and discomfort, reducing stress, and helping people live a high quality life. The goal for this type of care is to help patients, they're living with that serious and chronic illness, and they are trying to improve the quality of life through treatment and through various other interventions. So that's a key word right there is treatment. Okay. So what type of palliative care patients do we see? Chronic illnesses. Typically in our palliative care program, we have patients in their last 2 years of life, so they're living with this serious and chronic illness. They're sometimes very sick, but not quite ready for hospice yet. They're not, either they don't qualify for hospice or they're just not ready to stop treatment yet, and that's okay. That's their goal of care. So we see a lot of cancer diagnoses, we see heart disease, lung disease, kidney failure, dementia, HIV and AIDS, and then we also see ALS as well. So our palliative care, it does include clinical case management, so there are nurses on staff. They do visit once a month, 1 to 3 times a month, depending on what the level of care need is. So they will do things really, one of the, I think the more rich things that we are able to provide is we do have nurses who go to doctor's appointments with patients. So I'm sure we all know that it's really difficult to navigate this healthcare system, and sometimes you don't understand what the doctor told you. You don't understand what they're trying to say because there's medical jargon, and sometimes we need people to speak our language. So nurses will go with patients to doctor's visits, help manage their medications, kind of be that go-between in between the specialist and the PCP, the primary physician. It's not uncommon for our patients to have a care team that consists of 5-6 doctors. That's really difficult to navigate. And so keeping up with those appointments, knowing when you need an appointment, that's what our nurses really are really good at, helping to navigate that. Symptom management, that does go hand in hand with the coordination of care between the physicians. So our nurses will go out if there's some symptom issues, you need an increase in medication, whatever it may be, our nurses are on the phone with the physicians, making sure that those orders are getting put through, making sure they're being sent to the pharmacy you would like, as well as if you need transportation to get to the pharmacy to pick up those medications. They just really provide a lot of resources. Then we have social workers on staff as well who do help with a lot of the community resources. So Meals on Wheels, for example, we have a lot of patients on our palliative care program who are in need of transportation, Meals on Wheels, just getting connected with a PCP, a primary care physician. And our staff really work hard on those 3 things, as well as advanced care planning. So how do you pay for palliative care? Our palliative care program is free of charge. Like Chris mentioned earlier, we are primarily funded through philanthropy. So there's a lot of people in the community who really believe in our service and in our program and generously donate to make sure that our nurses and our social workers can get out there and help as many people as possible. Like we mentioned before, in-home visits from the clinical team. There's times when people don't want in-home visits and they just maybe want to check in Zoom. They do both, so they'll do telehealth and in-home. Psychosocial support, care plan coordination. We have volunteers available to our palliative care patients as well. And we obviously have our wonderful adult day program that falls under that palliative care umbrella that we have. We do also offer spiritual care assistance for loved ones and our palliative care patients. So hospice care is for people who are at the end of their life, end of their disease process. And this we'll talk about, but this is decided by physicians. So For hospice patients, we typically will get a referral from a physician. You know, your loved one may visit their primary care physician or their oncologist or whatever it is, and they say, you know what, we've done all that we can as far as treatment-wise. It's time to focus on quality of life at this point rather than curative. And so after that discussion, sometimes before, we get those referrals and we reach out and schedule an evaluation for your loved one and make sure that we're discussing with you as well. At this point in their life, the burden of the treatment really is outweighing the benefit. So we focus on symptom management and the quality of life rather than the length of life. So a lot of what we do when they say comfort care, we're focusing on those end-of-life symptoms, whatever that may be. It could be nausea, could be pain, it could be constipation, whatever it is that causes discomfort. Hospice is going to come in and make sure that we're managing all of those symptoms so that there is you don't have to go to the doctor's office. It really bridges that gap. The visits from clinicians are more frequent than on palliative care. So our hospice team, the nurses come out at least once a week, sometimes more often. If your loved one has a Foley catheter or maybe some wounds, anything like that, they may come out 3-4 times a week. Just really depends on the care plan. We have social workers as well. We're going to go over all the different disciplines in a later slide. But we provide emotional supports for patients and families. And here we'll talk about what's included. So the medical support, like we mentioned, it really shifts from that treatment type of care to focusing on comfort. Our patients at this point in their life they're done with chemotherapy, they're done with blood transfusions. They just want to be comfortable and they want to be home, wherever they call home. Coordination of supplies, our hospice, because they are at home, there are things that you need in the home to be able to have that comfortable life that you may not have had before. So hospital beds, supplies, walkers, wheelchairs, things that are going to help you navigate through your new disease process or the worsening disease process. And I'm just going to go back to this really quick. As our patient's disease process progresses, the visits tend to increase. We have what we call here at YoloCares Focus Care Program. So as we notice that our patients are at that end stage, they are what we call transitioning or imminent, our nurses bump up their visits. The nurses and social workers visit daily. So there's either a visit from each daily or they'll alternate. So we really kind of just all hands on deck and surround everybody when we can see that they are at the very end of their life. Okay. We also have visits from our wonderful chaplains and spiritual care counselors. A lot of times, especially at the very end of our patients' lives, these lovely individuals are great support to the families. So they're helping you navigate that. They're helping you process this new time in your guys' life. We also have our grief counselors who are amazing, and they offer extensive support before, during, and after a patient comes onto service and passes. So what to expect? Our clinicians, because we are not there 24/7, most of our patients, we pop in, for 30 minutes to an hour during our visits, however long it takes to manage symptoms. There's no real time frame on it. That's the average it usually takes. But if the symptoms are not, they're still there, still present, we stay as long as we need to. But typically, it's about 30 minutes to an hour. And so a lot of what we do is education to caregivers, to families on How can you help your loved one when we're not there, when we're on our way there and something's happening? So a lot of education on and training, hospice training on what to do and what to expect. We do have 24/7 nursing support. So we always have a nurse on staff, middle of the night. It always happens where, your loved one will be fine during the day, and then 2 o'clock in the morning, something happens. What am I gonna do, right? For people not on service, it's the ER, it's urgent care, or ER probably at 2 in the morning. But for our patients, it's calling us and our nurse comes out, or our nurse will help triage over the phone and help you if we can't get there in time. We're helping you over the phone while we're on our way. We have bereavement and the grief support before, during, and after death. Okay, so this one's really important, and this is because it's very regulated through Medicare. Hospice patients at this point in time, this may change in the future, but at this point in time, have to be deemed to have a life expectancy of 6 months or less, and this needs to come from 2 physicians. So how we manage that is, like I said, we will usually get a referral from a physician, the specialist or the primary care, and our team will go out and do an assessment and evaluation and contact our physician. That's the second doctor. They'll contact our doctor on call, let them know everything that's going on with your loved one, what has been the decline that you guys have seen to justify, why they should need to be on hospice, why they need that extra level of care, and our doctor will give the thumbs up or say, just not quite yet, maybe palliative care. So there's the 2 physicians certifying that. So hospice and palliative care both focus on symptom management. If you notice in the slides before, the real difference, you still get nursing care, you still get social workers on both levels of care, but the difference is really the treatment and the curative measures. So palliative care patients can be appropriate for hospice, but may not be ready to give up their treatment. And that's their goals of care, and we follow them and we walk with them through that until they are ready, if they ever do decide that they're ready to make that jump to hospice, because some people don't. Palliative care begins at the diagnosis and at the same time as treatment, whereas hospice care begins after all the treatment and if the disease is stopped and when it's clear the person's not going to survive regardless of the treatment measures and they're ready. So, like caregiving agencies, hospices are not built the same. So again, it's very, very important to do your research. It's very important to advocate for your loved ones. Ask those questions before choosing an agency. Medicare actually has a list of questions, it's quite extensive, that you should ask hospice agencies before choosing. So it asks them things such as, what are your typical caseloads? How many patients do your nurses have? What's your process for this? What's your process for that? And I would highly recommend that. I filled a couple of those out for prospective patients, and they did end up coming onto our service, but if you do a couple of those for different agencies, you'll really be able to see the differences in the care and the level of care that they're either able to provide or willing to provide. So make sure that you always have a choice in which hospice agency you choose. If your loved one is at a facility, some facilities have a preference on who they would like to use, and they may just say, we're going to refer to X hospice. If that's not what you want, you do not have to go with that. It is your right to choose. Sometimes it's other people's preferences do not align with yours, but if you are the decision maker, that's your right. Okay, so now we have the interdisciplinary team on hospice. We call this the IDT for short. And I'm going to go over just a little bit about what each discipline does on hospice. And just something to note here, you'll see that patient and family is right there in the middle. And that's because hospice care is meant to be patient and family centered. Okay, so hospices should not come in and take over the entire care. It's meant to be a joint care plan. So we really follow your lead and how you want the care to be, how your loved one wants their care to be. So it's always patient and family centered. Surrounded by you all, we have the physician who, like we talked about, makes the diagnosis, comes up with the terminal diagnosis upon that evaluation, and then will oversee, from a medical standpoint, the plan of care and the prognosis. So the medical director, the physician, is reevaluating the decline to make sure that that patients still qualify for hospice often. We talk about every patient every 2 weeks with the whole team. So the physician is discussing that with them, and sometimes our patients get better, and that's great, and then we graduate them from hospice, and we may see them again in another year. But there's just constant conversation around that with the physician. You have the registered nurse who will develop and implement the plan of care with family, with patients. So it's important to have a discussion about that. What is your goals of care for your loved one? What's your spouse's goal for care? What would they want? And then they make routine visits, and we have nurses who are available 24/7. We have social workers over here who provide counseling and emotional support. They'll assist with any financial or legal insurance issues. They help with advanced care directives, filling out a POST. Does anybody know what a POST is? POST, it's that pink form. That's good. That's a lot of people. Great. So that's the POST, physician's order for life-sustaining treatment. So that's going to tell, if somebody calls 911, that's going to tell the ambulance if you are a do not resuscitate or if you are that you want CPR, along with other things. They'll help you with that, as well as advanced care directives. We have spiritual care counselors, so they explore any spiritual issues. We have spiritual care counselors visiting people who are not religious. You don't have to have a religious preference to have them visit. They are an extra set of eyes for your loved ones. They are a lovely company for you. We're really, really good people. They connect patients and families with faith and community. And then they also are available to attend the funerals after as well. We have that often. Home health aides. I would argue these individuals are the favorite. They are the people who come in and help get your loved one all cleaned up. Their visits are usually at least an hour. They do a really, really good job at building relationships with your loved one to make sure that they feel comfortable, because they're the ones seeing them at their most vulnerable, right? To take a shower. That's one of the hardest things for people to give up and people to accept needing help with is their personal care. It can be embarrassing. And so the home health aides do a really, really good job at building that relationship, and a lot of times they're the only ones that the patients will feel comfortable with, and that's great. So they come up to 5 days a week for patients who have no caregiving or meet specific criteria, like very set criteria. We do offer 7 times a week, but those are very extreme cases. Then we have, and they will do light housekeeping as well. They'll change the bedding. They'll do range of motion exercises with your loved one, those sorts of things as well. Then we have our volunteers who support the patient and family through respite or companionship. Also are available to help with things like arranging transportation and whatever else comes up. We have a great volunteer program that has a ton of different sub-programs in it, which we can get you all as well. And then we have our bereavement counselors who offer support groups, one-on-one counseling. We have the YoloCares for Kids, as Elisa mentioned earlier. And again, those services are provided 13 months after death of the loved one as well. Did I miss anybody? So you're the caregiver and you're still managing your loved one's care. What's your role with the hospice? Again, your role is really to lead. You tell us what you want. You tell us what your loved one is wanting. We'll help you, we'll guide you. You know, we're the end-of-life experts. We will make recommendations and we won't do anything that's not safe, but we really meet people where they are and where they want to be, and you lead that. So if you notice that your loved one is needing some more help, some more assistance, and you just don't know what to do and how to navigate that, what could you do? You could obviously speak with your primary care physician, your loved one's primary care physician, but most importantly, even if it's just questions on where do I go next, what do I do, you can always call YoloCares. And somebody in the intake department, myself, there are various individuals who will answer any questions you have and point you in the right direction. They could be palliative care appropriate, and we tell you, they sound like they're palliative care. We'll reach out to get an order if that's okay for you, or hospice or whatever it is, but we'll really kind of let you guys lead that, see what you're looking for, and go from there. But you can always call us no matter what. You don't need an order from a doctor to give us a call. And then thank you for taking time to care for yourself. That's it.